that is actually as a result of this sudden exit without really, I don't know. It's so inhumane. I can't, sometimes when I talk, I feel emotional because of the situation where we are. Nobody would do that. I think it's unimaginable that somebody can just do that to people. It's like a mother
pulling out like that.
abandoning the child in the dustbin, and you go, that's how we compared it.
Hello, I'm Françoise Girard with the famous podcast, and today we're speaking to Monica Oguttu, a nurse-midwife in Kenya. Monica is the founder and the Executive Director of KMET, the Kisumu Medical and Education Trust, which provides healthcare services, information, and does advocacy in Western Kenya and in several counties across Kenya, ensuring that women have access to sexual and reproductive health care, including safe abortion services. KMET obviously is on the ground in Kenya and has been observing the cuts, the USAID cuts to foreign assistance. And Monica can tell us a bit more today about how that's playing out on the ground. Let's talk to Monica. Hello, Monica. I'm really pleased to see you today.
Hello, FG.
Yeah, today we're going to discuss the impact of the dramatic funding cuts for foreign assistance that the Trump administration has implemented in the last few weeks. You live and you work in Kenya. You're based in Kisumu in Western Kenya. And while your organization, KMET, did not have USAID funding from the U.S. government, there are other organizations in the environment where you work who did. And so I'm wondering if you could tell us how the Trump cuts to USAID and to foreign assistance are playing out in your community in Western Kenya.
Thank you. That's a great question, especially at this time. The Trump cut it's a disaster. Let me use that word because it disrupted everything. As you know, we in Kenya, we have very limited resources. And therefore, one thing that we have done is to work as a team. There is always no silo work. We come together, we offer integrated services so that we are able to reach the underserved communities, through synergies and leveraging each other. So the disruption of these services, especially funding to HIV, PMTC, malaria, TB, that were all funded by USAID, including the RAMCA, Reproductive, Maternal, Child, Adolescent Health, has really affected what we do. And we are right now re-strategizing on how to go about closing the gaps that are there, because we work with quite a number of other USAID-funded NGOs and CBOs in the space.
Community-based organizations, yeah.
Yes, the community-based organizations. Thank you.
Mm-hmm. I mean, you started naming some of the areas where the funding has been cut: tuberculosis, malaria, PMTCT, which is prevention of mother-to-child transmission of HIV, HIV treatment and prevention itself, childhood vaccines also, and the full range of child and adolescent health. You are one organization, and you have, your own mandate, which is adolescent and young women's health, but you cannot take this on yourself. Like, you can't substitute yourself for all these missing funds, right? So how are you when you say you're strategizing and doing synergies, what can you really do in practice?
Yeah, as you have rightly put it, no one organization can do all this together, even if you have all the funding alone. So we had to sit back. In Kenya, we always say when a snake bites you, you don't stand there because it might bite you again and it might be even more lethal. So you run away. So what we did is to accept that we have been beaten and regroup and re-strategize. So we have had meetings at different levels. The first was the community, because we had to tell the community what is going on. Some of us don't understand how maybe funding from US can affect a village in Kenya. So we had to start from there to educate our communities, for them to understand what is going on, so that it is not really something that is only known at the highest level, maybe Nairobi or Kisumu, but we went up to the village. So we were able to, regroup with the same community-based organizations, go to the community using the little resources we had to inform the communities through their structures, because in Kenya we have the community health strategy structure. We work with the community stakeholders, the chiefs, the churches, the schools, women groups, youth groups. So that was the first thing we did. Then very quickly at the county level, because health is devolved in Kenya, we had to, again, as partners in each county, meet and understand that it is a reality. What are we going to do together? Like in one county, Homa Bay County, that has really been hit hard. It's the one of the counties with the highest HIV prevalence, highest teen pregnancy, and also high cases of malaria. So there were quite a number of partners in that county. In that county alone, when we did a quick assessment, over 1,000 staff have been laid off. So you can imagine the gap that this is creating. So again, we had to engage the county government. Of course, they invited the partners. We had to meet and re-strategize and agree on what exactly are we going to do.
And when you say 1,000 staff, you mean health personnel, nurses,
yes,
that kind of stuff.
Personnel.
Yeah.
Exactly, that is what I mean. Some of them are nurses, laboratory technicians, doctors. We have community health workers. We have also a number of health promoters, but majority being the nurses and the lab technicians, doctors, that were supported through the USAID funding. So they have been laid off. That is just one county. We still don't know how many counties, the number in the other counties. So we use just that one county as a model, as an example. So, and the human resource is the backbone of every service delivery. If we want to offer services, no human resource, no supplies, no services. So it has been a huge, huge impact. But we are managing now. We came up with new innovations on what to do. If you put your heads together, you can be able to manage the situation, even if it's in a little way. What is it that we are going to do with the little resources? So that is what we did. And one of the priorities that we came up with was to now start mobile clinics. And for us as KMET, because I'll talk as a KMET organization, we have bought a van. We call it the Cow Clinic on Wheel.
Cow.
And this is Cow. That name came from the community because they value it. Cow is a very valuable animal. So it's a clinic on wheel. It's a complete clinic. with support from two partners. One is the one who bought it is Altro. And of course, the staff running, the three staff that are there, two nurses and the laboratory technician, in partnership with the county health department, because they also give us staff when we are in their region. The staff we are paying from support from EFMOS.
And these are foundations, foreign foundations or local foundations? EFMOS.
EFMOS is from your support.
Oh, my support.
Yeah, and famous, then Altro Foundation is based in UK. Mm-hmm. So that is the immediate priority strategy that we came up with, that we need to get out. We need to go out there and offer services. So we are doing vaccinations, we are doing HPV, we are doing post-abortion care. We are able to do contraceptives. We are able to refer cases that need to go to the next level. And it's a functional referral system where we call the other side and the clients go when they have been booked, so that they don't stay for a long time due to the shortage of staff. So it's a complete integrated mobile clinic. We also do antenatal clinic. In there, we have a complete lab within in the mobile clinic and a pharmacy. And we have pulled together a few organizations to make sure that it's running. We have also reached out to the local corporate partners. For the first time, we have seen a great response from our corporate partners, the banks.
The banks, the private sector.
The private sector. So we reached out to them because we had to inform them this is the situation, especially the banks. These are their clients that are going to suffer with no services. So we had a meeting, we had two breakfast meetings with the banks, one in Kisumu, one in another county called Bungoma. And we agreed on the strategies on how to involve the private sector. And two banks, one is Stanbic Bank and one is Kenya Commercial Bank. They have greatly come out to support what we are doing out in the community. The mobile clinic has also cervical cancer screening because it's a big issue in that region, where there's high HIV cases, there's also high cases of cervical cancer. So we have a machine, we call it's called the thermoablation. You are able to screen and the early lesions you treat on site, so that it's early intervention.
For
we are now focusing.
Cancer.
Exactly. Yeah, so that's what we are doing with the little resources we have, but everybody is now aware on the impact, because we didn't want people to leave the health service providers or the leadership to struggle with it. So everybody understands what is happening, and therefore it's our problem, all of us, and we have to come up with the solutions.
Right. But obviously I'm really impressed by how fast you've sort of pivoted to informing the community and then finding some stopgap solutions to reach people in the meantime. But there must be a big gap still in the kind of coverage you can provide with your cow, your clinic on wheels, and and what was available before. Am I wrong?
You are actually right, because this is just a tip of the iceberg. These are just, we're just covering right now like 3 counties. Remember, we have 47 counties. So I'm just giving an example of what we have done as an organization, but the gap is huge. Yesterday was just, I'll share with you what the Council of Governors and the county governments have done, because they also came together at the highest level. All the governors came together and the county governments to see how they are going. It's not going to be an immediate something that we can do immediately to close the gap. But now they are coming up with the high-level solutions to the USG stop work order, and also the support from USG. So what they said verbatimly is that following a high-level meeting this week on the impact of the USG stopover work and support, stakeholders, as stakeholders, we have resolved to, among others, do the following. One is to allocate additional funding for human resource for health, vaccines, HIV commodities, family planning, the health management information system, because all these were supported by USG. Then they are also going to redesign service delivery mechanisms to integrate. The word here is integration, because that is the way to go. Initially, there were vertical projects, but now it will integrate HIV, TB, malaria, and reproductive, maternal, adolescent, child health programs. So it will all be integrated. Then lastly is to collaborate with the Senate, the Assembly, and the Treasury to allocate budgets to bridge the funding gaps.
Right.
They said we have to establish a coordination framework for partner support. The partners on the ground that are struggling will be supported. So this is towards sustainability and efficiency to address the interrupted service delivery, service delivery, which remains a key priority to our government. So this came yesterday, and it was shared. So it's encouraging, you know.
Right. So I was asking you, this is all good, maybe an opportunity, but it's also done in a crazy way, right? Through an emergency, which no one was expecting without any notice. So.
Yeah, sure. As I mentioned earlier, it was a shocker.
Yeah.
A big shock. One thing we didn't expect from the US government is that sudden closeout. For us as KMET, we are used to the sudden the overnight. We expected maybe due to the huge support that they give to the governments. I know it's not only in Kenya. They would give a period. And, like a winning period, saying maybe if it's shortest 1 year or 2 years, we are closing out. And therefore, you need to have local strategies to continue or to take over. Usually, other donors call it the transition period. So we expected a transition period. But the shock has been so huge that it has brought a lot of challenges, especially human resource. It's a January. You have just started off the year. Most of these staff, they have their children in schools. You have just maybe gotten a new school for your child. You have gone to a new town, because some of them were saying they got their contracts last year in August because they were starting new projects. And you are settled because it's like a 5-year grant, you'll continue, you have settled. So it's both, it's all around, apart from just the government to government, G to G issues, it's also the human resource, is the community, the social impact. So it's all around. So with all those, we had to take it as a positive move for us, because I mentioned when you are bitten, you don't stay there. So we took it up and said, okay, you cannot keep crying. You cannot keep mourning over something that will not change. At one point, we thought that there would be renegotiation, because somebody said they were still negotiating. but we saw that it's not forthcoming. It was just maybe PR or something like that. So we had to now take it as a positive, on a positive angle to move on and see what we can do. We know quite a number of indicators. Our indicators are going to change. We know that, especially where we work, we had partners who are complementing what we are doing. We were working as a team, complementing the government's efforts to reduce the mortalities. So we anticipate high mortalities because for us, as we offer post-abortion care and we ensure that no woman dies from unsafe abortion, we have also linked with other providers who offer post-abortion family planning. This funded by USAID, postpartum family planning, because that was a new innovation where women deliver and immediately they get the postpartum immediate after delivery FP, because some of them go
Family
very far
planning.
and they don't come back. Yeah, so I think that's why we are doing a baseline right now. In all the counties, we want to do the situation as it is. Next year, we will be comparing the changes because we want to confirm that that is actually as a result of this sudden exit without really, I don't know. It's so inhumane. I can't, sometimes when I talk, I feel emotional because of the situation where we are. Nobody would do that. I think it's unimaginable that somebody can just do that to people. It's like a mother
pulling out like that.
abandoning the child in the dustbin, and you go, that's how we compared it. You have delivered, because this is delivering the projects. They delivered these projects, and suddenly you abandon that child in the dustbin, and you don't care whether that child is crying. You are walking off, going, and the child will die, and you don't care. So I think it's so inhumane. I don't know how to explain it, but
yes,
we know we will, with God, we will reach somewhere. We have started a new journey.
You at KMET, you and your partners provide abortion care and abortion pills, right, to thousands of women every month across Kenya. And of course, you don't have USAID funding. You never had USAID funding for this because the government, US government, does not and has never funded abortion services in Kenya. Still, this must have an impact on the work on abortion because of the impact on all of reproductive health services, no? I mean, how are you seeing, are there more women now in need of abortion because they don't have access to contraceptives? How does this work in practice?
Yeah, I think it's so early to give the exact situation as it is right now on the issues around reproductive health in general. Because in Kenya, we look at all the big five that kill women. We don't look at only an abortion. So when we'll be looking at all the big five, the number one big five is the postpartum hemorrhage.
Yeah.
That kill women. I know when people come to Kenya, they talk of the big five in the game park. For us as service providers in maternal health, we have also the big five. Number one is that hemorrhage.
The big killers of
and
women.
That, yes, loss of heavy bleeding after delivery. Then the second one is always the hypertensive disease in pregnancy. The third one is the sepsis infection. The fourth one is
obstructed labor.
I've talked of obstructed labor.
Yeah.
You're smart.
Yeah.
Obstructed labor, and the last one is the unsafe abortion.
Right.
So when we look at all the indicators, we look at all the big five. And unsafe abortion, we have been looking at unsafe abortion comprehensively. looking at the comprehensive abortion care. From the prevention, it has been a journey. The prevention in terms of giving the right information on how to prevent it. So that's how we do a lot of work on adolescent sexual reproductive health, because we want to meet them early so that we give the right information. So every cohort has a package. So like the adolescent sexual reproductive health, the adolescents have the package in terms of the information package and the referral pathway. Where do you get the services? So where do you even call? We even have toll-free lines where they can call and get services. Then we have now another cohort that just needs family planning, contraceptives. And remember, all these have been disrupted.
Yes.
Because UNICEF has been affected and that has been giving the vaccines. UNFPA is affected, has been supporting the contraceptives. So all the other partners have been affected. So it's not only like you would be saying we'll offer service. How do you offer services without all these complementary partners that have been supporting your work?
Yeah.
So the family planning contraceptive clinics are also integrated. So when they go to those clinics, they are able to get the information. In case a method fails, what do you do? Because usually without the right information, they'll go to quacks. And this is what KMET has done for years. Preventing. We don't want any woman, any girl to go to a quack because they lacked information. Then we have now the
end up with an unsafe abortion. That's what you mean by quacks?
Exactly.
Right.
And it's a very silent killer because nobody even keeps records. They fear keeping records because sometimes you are reprimanded for that because why did you handle the abortion case? But as service providers, I'm talking as a service provider, you cannot leave a woman die because you are getting funding from a partner who does not want you to talk about it. You'll be part of the contributing factor to that death. When somebody asks a question, what caused the death of Mrs. X? You are part of it because you didn't give the right information. So we are telling all providers, give the right information. It's up to the woman to make informed choice. It's not us. So we also link them with the providers where they can continue with the counseling and even getting safe services. Because for you to save a life, you need safe services. But if you don't give information, it will be a reverse referral. They'll be going to quacks. And that is what we are saying no to.
Yeah. And you certainly have done a lot to stop that. As you told me another time, you said, we are flooding the zone with information about safe abortion methods and where to get abortion pills and to prevent young women, particularly, from ending up with these quacks. But as you just noted, if other partners are not there providing it, you can't do everything, right? You need others to provide information,
exactly,
and contraceptives, etc. You're not. KMET is fantastic, and you're operating in many counties in Kenya, but you can't do this alone, right?
Exactly.
It's an ecosystem.
So we need all these partners.
Yeah. One thing I was pleased to hear from you that the governments are starting to react and to think about providing more funding and integrating services. It's time, right? I mean, the sustainability of the health system in Kenya needs that, right? That government involvement.
Yeah. For sustainability, even with external funding, as local partners, this is the time for us to really drive that home. And it's being done by the local partners. This is the time localization drive is working because we are telling our governments, even if other partners will come to bridge the gap, some might come to bridge the gap. Some are already showing that interest to support. But you are always safe with your own.
Right.
So we have to really invest a lot on advocacy and making sure that our leaders, right from the county level, from the community level, from the national level, understand the need to actually budget for these critical services that we need to offer. because you cannot keep on relying on external, funding. So that is what we are doing right now. As you know, advocacy is not so much well-funded. We are looking for partners to support that. We have done it that well with the adolescents work we are doing. So we want to go, to a higher level. And we are also bringing other community voices together. We have learned from other counties that the communities need to speak and demand for services. So what we are doing and what we think will work for us is to empower women at the grassroots level to really hold their leaders accountable for these services. There's what we call in Kenya public participation. During the budget cycle, the people go to the community to get the voices of the community members. And most of the times we miss the point. You get people talking about roads, constructions, maybe a bridge that was broken somewhere. But we need to help these women to really demand for these services because sometimes they don't know what to ask for.
Right.
So that is also one priority area going forward, to give the communities and the women the voices. Because for us as KMET, we believe that unless women are empowered, there'll be no development, because we need to make that change. It is the only power that women have, and that's their voice or their mouth. They need demand for these services, because every woman, every community member has the right. It's not a favor they are doing to them. They have the right to access quality reproductive, maternal, child, adolescent services in Kenya. So that's what we are singing, and that's the message we are taking home.
Thank you so much, Monica, for telling us how things are going on the ground, and also for giving us this message of hope. It's guarded hope. There's a lot more to do, but that you are all acting and reacting and moving to try to do the best for your community. Thank you so much, and a luta continua. The fight continues. Thanks.
And we hope to keep you updated. Maybe by June, I'll tell you what's going on, because we are picking quarterly information. So from now up to end of April, there'll be some information. Then from there, another information. So
great.
Yeah, we'll keep you posted. Thank you. But it's a journey of hope.
Yes, we'll check in with you. Bye-bye.
Bye.